we will start discussing the anatomy of the leg in a few lectures. Regarding the bones of the lower limb, we have the tibia and the fibula. We also have a small bone in the front of the knee. We call it the patella, اللي هو بالعربي عظم الرضفة. The patella or the kneecap is a largest sesamoid bone within the tendon of the quadriceps femoris muscle. It is situated in an exposed position in front of the knee joint and can easily palpated through the skin. It is separated from the skin by an important subcutaneous bursa. We call it the prepatellar bursa, as seen in this figure. This bursa might get an inflammation or infection to form a condition, what we call it bursitis or prepatellar bursitis. Regarding the patella itself, the posterior surface of the patella covered by hyaline cartilage and articulate with the femoral condyles at the patellofemoral joints. The patella is triangular in shape. Its apex lies inferiorly, giving attachment to the ligamentum patelli or the patellar ligament. The upper, lateral, and medial margins gives attachment to the quadriceps femoris muscle. Regarding the function of the patella, its play roles in the knee extension. The patella also increase the leverage that the tendon can exert on the femur by increasing the angle at which it acts. معناها acts as a pulley to increase the strength of the quadriceps tendon. The patella is prevented from being displaced laterally during the action of the quadriceps muscle by the lower horizontal fibers of the vastus medialis and by the large size of the lateral condyle of the femur. Traumatic dislocation of the patella يعني خلع عظم الرضفة resulting from direct trauma to the quadriceps attachment of the patella, especially the vastus medialis. So, injury of the vastus medialis lead to lateral dislocation of the patella. The tibia. Tibia is the large weight-bearing medial bone of the leg. It has an expanded upper end and smaller lower end and a shaft. Tibia, it articulates with the condyles of the femur and the head of the fibula above and with the talus and the distal end of the fibula below at the ankle joint. So the upper end articulate with the femoral condyles at the knee joint and the lower end articulate with the talus at the ankle. At the upper border are the lateral and medial condyles. The lateral and medial tibial plateaus which articulates with the lateral and medial condyles of the femur. Anterior and posterior intercondylar areas separating the condyles. There is an area between the two condyles, usually it's an elevated area تسمى الهضبة, separating between the medial and lateral femoral condyles, containing also the intercondylar eminences or the spines of the tibia. Tibia has lateral condyle, possess on its lateral aspect a small circular articular facet for the head of the fibula. So the lateral upper part of the lateral condyle containing a depression for the articulation of the head of the fibula at the superior tibiofibular joint, which is a synovial joint. The medial condyle has on its posterior aspect the insertion of the subtalar muscle. This is the facet for the articulation of the head of the fibula, and this is the attachment of submembranosus muscle at the posterior tibial condyle. The shaft of the tibia is triangular in shape or in the cross section, presenting with three borders: anterior, medial, and lateral border, and three surfaces: medial, lateral, and posterior. So this triangle having an apex pointing anteriorly. So we have the medial and lateral surfaces and posterior surface. Anterior and medial borders with the medial surface are subcutaneous. The anterior border is prominent and forms the shin. The shin of the tibia, it is the prominent anterior border. At the junction of the anterior border with the upper end of the tibia is the tuberosity, which receives the attachment of the ligamentum patellae. So the upper border, in its upper part closing to the knee, we have the tibial tuberosity giving attachment to the ligamentum patellae, or what we call the patellar ligament. This is the patellar tendon, and this is the tibial tuberosity. The anterior border becomes rounded below, where it becomes continuous with the medial malleolus. So the anterior border distally and medially forms the medial malleolus. The lateral or interosseous border gives attachment to the interosseous membrane. This is the tibia, which is triangular in shape, containing the anterior border, lateral border, and medial border. Regarding the posterior surface of the shaft of the tibia, it shows an oblique line, what we call it the soleal line, for the attachment of the soleus muscle. This is tibia from behind. The upper posterior surface contains soleal line. This is the soleal line. The lower end of the tibia is slightly expanded. On its inferior aspect, a saddle-shaped articular surface for the talus. There is a concave surface for the articulation with the talus. The lower end is prolonged downwards medially to form the medial malleolus. The lateral surface of the medial malleolus articulate with the talus. On the lower end of the tibia, there is a wide, rough depression on its lateral surface for articulation with the fibula. The fibula is slender lateral bone of the leg. عظم الشظية fibula has an expanded upper end, the head, with a shaft and a lower end. It takes no part in the articulation at the knee joint, but below it forms the lateral malleolus of the ankle joint. The head of the fibula has styloid process and articular surface for articulation with the lateral condyle of the tibia at the superior tibiofibular joint. The shaft of the fibula is long and slender. Typically, it has 4 borders and 4 surfaces. The medial or the interosseous border gives attachment to the interosseous membrane. The lower end of the fibula forms the triangular lateral malleolus, which is subcutaneous. On the medial surface of the lateral malleolus is a triangular articular facet for articulation with the lateral aspect of the talus. Below and behind the articular facet is a depression called the malleolar fossa. This is the articular facet lined by hyaline cartilage to articulate with the lateral aspect of the talus. And this is the malleolar fossa to articulate with the distal end of the tibia laterally by the inferior tibiofibular joint. Regarding the cutaneous innervation of the leg, the front of the leg is innervated by 3 nerves. The lateral cutaneous nerve of the calf comes from the common peroneal nerve, the superficial peroneal nerve from the common peroneal nerve, and the saphenous nerve, which is branched from femoral nerve. Regarding the venous drainage of the foot and the leg, numerous small veins curve around the medial aspect of the leg and ultimately drain into the great saphenous vein. The great saphenous vein drains the medial end of the dorsum venous arch of the foot and passes upward directly in front of the medial malleolus. Its veins ascend in company with the saphenous nerve in the superficial fascia over the medial side of the leg and reach the upper thigh to enter the saphenous opening and join the femoral vein. It has numerous valves. Surgical importance of the great saphenous vein: it is the commonest site for venous cut down. Venous cut down, a surgical operation done under local anesthesia. By this operation, we do direct cannulation of the vein. We put a cannula or a catheter inside the vein under direct vision. This is done for the shocked patient. Regarding the innervation of the back of the leg by four nerves: the posterior cutaneous nerve of the thigh, the lateral cutaneous nerve of the calf, the sural nerve, and the saphenous nerve. The back of the leg has numerous venous supply. Small saphenous vein arises from the lateral part of the dorsal venous arch of the foot. It ascends behind the lateral malleolus in company with sural nerve. This vein also containing valves, which are one-way valves, permits to a transfer of blood upward and prevent it from spillage down. It has important anastomotic branches join the great saphenous vein behind the knee joint. At the popliteal fossa, the small saphenous vein pierces the superficial fascia and join the popliteal vein. Regarding the fascial compartment of the leg is surrounded by superficial fascia and deep fascia, which are continuous above with the fascia of the thigh. Below the tibial condyles, the deep fascia is attached to the periosteum on the anterior and medial border of the tibia. The peroneus is a thin fibrous membrane covering the bone. The interosseous membrane is a fibrous sheet, binds the tibia and fibula together and provides attachment for neighboring muscle. So the function of the interosseous membrane binding the tibia and fibula gives attachment to the neighboring muscle. Two muscular septa passes from the deep fascia, the anterior and posterior intermuscular septum attached to the fibula. Septi and the interosseous membrane divide the leg into anterior, lateral, and posterior compartment, each having its own muscle, blood supply, and nerve supply. So this figure illustrates the attachment of the intermuscular septum into the medial and lateral border of the fibula. This is the anterior intermuscular septum. This is the anterior one, and this is the posterior intermuscular septum, or the posterior fascial septum, and this is the interosseous membrane between tibia and fibula, divided the leg into three compartments: the anterior compartment, the lateral compartment, and the posterior compartment. Anterior fascial compartment contents the muscles are tibialis anterior, extensor digitorum longus, Peroneus tertius, and extensor hallucis longus. Blood supply anterior tibial artery. Nerve supply deep peroneal nerve. Regarding tibialis anterior, it originates from lateral surface of the shaft of the tibia and interosseous membrane, and inserted into the medial cuneiform on the base of the first metatarsal, supplied by the deep peroneal nerve. Function: extend foot and ankle joint, a movement called dorsiflexion of the ankle. Innervate inverts foot at subtalar joint and transverse lateral joint. Inversion is lateral tilt of the forefoot at the subtalar and mid-tarsal joint. Mid-tarsal is the same name for the transverse tarsal joint, mean the talonavicular and calcaneocuboid joints, and holds up the medial longitudinal arch of the foot. Extensor digitorum longus, originating from the anterior surface of the shaft of the fibula and inserted into the extensor expansion of the lateral four toes. Nerve supply: deep peroneal nerve. Its function: extend the toes, extend foot and ankle joint. Regarding the extensor expansion, is a facial expansion that the central part of the expansion is inserted into the base of the middle phalanx and the two lateral parts converge, يعني unite, to be inserted into the base of the distal phalanx. This is the extensor expansion. Gives attachment to the extensor tendons. All extensor tendon: extensor digitorum longus, extensor digitorum brevis, extensor hallucis longus and extensor hallucis brevis, all are attached to the extensor expansion. Peroneus tertius. This is a small muscle, arises from the surface of the shaft of the fibula and inserted into the base of the fifth metatarsal bone. Nerve supply: the deep peroneal nerve. Function: extend foot at the ankle joint, where everts foot at subtalar joint and transverse tarsal joint. So it is play a role in extension of the ankle and foot and eversion of the foot. The muscle everts the foot with the peroneus longus and the brevis muscle. Extensor hallucis longus, originating from the anterior surface of the shaft of the fibula and inserted into the base of the distal phalanx of the great toe, supplied by the deep peroneal nerve, who acts as extensor of the big toe, extend the foot at ankle joint, and also inverts foot at subtalar and transverse tarsal joints. So inversion is inward tilt of the forefoot. Thank you for your listening.